All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic was recently published in the Journal of Law, Medicine, and Ethics, which is titled Addressing the Problem of Brain Death Misdiagnosis. And today, our guest will highlight some of the controversies around this topic. We are so grateful for our guest today. This will be her third time with us, so I have the pleasure of reintroducing Catherine Drabiak, who's a professor at the University of South Florida College of Public Health and College of Medicine. She's also co-director of the Law and Medicine Scholarly Concentration Program at USF's Morisani College of Medicine. Her teaching and research is focused on health law, public health law, and medical ethics, and she's currently a member of Advent Health's Medical Ethics Committee. So our format today will be a presentation. We'll have a few minutes at the end. If anybody has any questions, feel free to start typing them whenever you'd like, and we'll get to them. And with that, welcome back, Catherine, and I will hand the mic over to you.
Yes, thank you. I'm so happy to be here. My name is Catherine Drabiak, and I'll be talking about brain death misdiagnosis today. So, a quick overview of what I'll be covering, why accuracy matters in the exams for determining brain death or death by neurological criteria. I'll go over the legal requirements, and then most of you are probably familiar with the clinical guidelines, but I'm going to be highlighting some inconsistencies between the legal requirements and the clinical guidelines and getting out why that's important. And then I'll be looking at the issue of inadvertent misdiagnosis and then the ethical reasons that it's important we want to get this right and be accurate. And you can see linked below two publications. So one is the actual paper in Journal of Law, Medicine, and Ethics, and one is covering the topic that just arose a few months ago in the summer, which was brain death diagnosis in a woman who's pregnant and what to do in those types of cases. So why does determining death matter? Well, about 2% of all hospital deaths constitute death by neurological criteria. So it's affecting a significant number of patients overall, even though it seems like a small percent. And it also matters if we think just about the clinical aspects and the societal aspects of why does it matter if somebody's dead or alive? So the clinical pieces would be, well, you need to get informed consent if patients are alive. You would be talking about removing life support. But if the patient is dead, the language changes because it's no longer a patient, it's a body. So it's custody of the body or different aspects related to organ donation and the organ donation process. Societal reasons matter also. So whether a person is alive or dead depends or correlates with if they have constitutional rights or not, meaning people don't have a privacy right if they're now dead. It also affects things like wills or marriage, insurance, inheritance, things like that. So the problem comes up when we think that, well, everybody's doing it the same, but in fact, they're not across states. So there's this problem of non-uniformity where a patient could be alive in one state and dead in another, and that's a problem. So there's also two other problems that I'll talk about, which I group into two categories referred to as false positives or inadvertent misdiagnosis, two different buckets. So why is it important to be accurate in addition to the reasons that I mentioned? Well, it's important for families to know if the patient is actually dead, so avoiding false hope and then going through the coping process of accepting and grieving the loss of their loved one, making sure that it's clear, is the patient alive or dead? Kind of getting rid of some of that gray area. And physicians, if you think about it, have an obligation to record the time of death. So when did the death occur? And kind of that bright line that is so helpful in medicine. So you all are probably familiar with the Uniform Determination of Death Act, which was this model law that's been around for a long time that essentially says that an individual who has suffered either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. And then this kind of puts a provision in that says, well, how do we figure this out? In accordance with accepted medical standards. So it's kind of this point to the medical profession to say, well, you figure out how to determine that. So this was a model that was adopted, and states can choose pieces of this language, and all states have. Some states have added on different provisions or have slight variations, which I'll talk about just a bit. So, Wisconsin law, I have to admit that before this presentation, I didn't know what Wisconsin law exactly was. So, this is it. Very simple, interestingly. It models what the model law is. So, again, irreversible cessation, all functions of the entire brain. And the reason why I'm bolding this, you'll see in a moment. And figuring this out and conducting the clinical exam has to follow accepted medical standards. So, why am I pointing this out? Well, other laws are different. So, when I've given this presentation, for example, in Florida, my home state now, to clinicians at Advent Health, there's additional things that they have to think about. So, for example, there has to be two physicians making this determination. There's requirements around what types of physicians. And they get kind of this liability protection that physicians in Wisconsin don't have. So, slight differences that would be important if there are physicians who are potentially moving from one state to another, which is sometimes common in practicing in different states, or move during the course of their career where they thought, well, I was familiar. I've been diagnosing brain death for years, but the state law requirements might be different in their new state, potentially have more elements that they need to follow. So, what are some of these differences across states? Well, I've grouped them into these types of categories. So, as you saw in Florida, that you don't have in Wisconsin, you have much more leniency that some states like Florida specify the type of provider that needs to conduct the test, or specifies potentially two physicians are conducting the exam. States also vary on this big thorny question of informed consent. So, for example, what if the family is objecting and says, no, I do not want you conducting this neurological exam or conducting the apnea test? So this has split in different states. So the general principle, we know that informed consent is required for any exam or diagnostic test on a patient who is alive, and the patient is alive until we determine otherwise. So this is kind of a catch-22. So there's been litigation over this, and it's produced opposite outcomes. So for example, in Virginia and Nevada, the law says there that no, physicians don't need informed consent because it's kind of different. They're trying to determine, has death occurred? It's not like other medical procedures. Other states, like Montana and Kansas, say, yes, you do need to get informed consent because it's a medical procedure on a patient. So we're following that same standard for informed consent. So this is a thorny area. Then we get to accommodations and exceptions. So, in all states except for New Jersey, they follow this law that if there's irreversible neurological cessation of all functions of the entire brain, that's clinical legal death. New Jersey has this kind of opt out clause that says, well, if you have a religious belief, and there are many that do not recognize brain death, then you're not dead. So this is an interesting little caveat. And then finally, as I mentioned in the beginning, several states, and I should note a minority of states, have addressed what to do with patients who are pregnant, who are gestating a fetus, where the fetus is alive and the patient is legally clinically dead, like we saw in the Adriana Smith case. So many states have not addressed this. The ones that have, Minnesota and Oklahoma, say, well, follow the wishes of the pregnant patient. And of course, she can't speak anymore, so likely her husband. Or in Nevada, maintaining support if it's probable that the fetus will gestate and develop into a live birth. So again, different standards. What do we do? So this is something where it would be important to clarify if there's not a state law to potentially develop a hospital policy in anticipation that, yes, this is exceedingly rare that it occurs, but should it occur, there should be a hospital policy in place to handle it. So, going back a bit more to the issue of informed consent. So, this has, I would say, garnered significant debate in the literature. So, what's the purpose of informed consent? We know all of these ethical principles, right? So, trying to guard against paternalism, ensuring beneficence, respecting patient autonomy, the right to bodily integrity, upholding trust in the medical profession. And this is something that I think is often lost, but respecting the moral status of each person. So their decision-making authority to say yes or no to things. And again, exercised on behalf of the patient from their surrogate decision maker in these types of cases. So there's quite a few arguments saying, no, we don't need to get informed consent to conduct the DNC exam. And here's the reasons why it's different. So there's a lot of arguments that say, well, it's like an exception. It's like how physicians provide emergency treatment under the principle of presumed or implied consent. It should be the same thing. And then there's also an argument that, well, it's not healthcare, it's kind of this evaluation, and we need to do it, right? Otherwise, we don't know if the patient's alive or dead. Then on the other side, we see, well, wait a minute, why is this different? If we require informed consent for all other medical procedures to make sure that we're upholding the values in this box on the side of the screen, that we should require informed consent here. It's not an emergency, and there are distinct risks and complications from both the exam and, in particular, the apnea test that could harm the patient. And a few articles talk about that if the patient is medically fragile and potentially in a compromised state, the apnea test could be the action that induces the patient's death. So it could be severe harm caused to the patient. So, what is the distinction? We talked about what the law is. Now, the clinical guidelines. I want to kind of add this into the mix. And where is this controversy coming from? So, the clinical guidelines give the checklist of kind of what to do to rule out and how to conduct the DNC exam. So, standardized protocol, right? Check off the boxes. So, determine, well, what's the cause of the neurological injury? Rule out mimicking conditions, and go through all of the other steps of the exam, like reflexes, responsiveness, then the apnea test, and only use ancillary tests if the apnea test can't be performed. So the issue with the clinical guidelines is in 2023, the American Academy of Neurology said, well, wait a minute. We think that irreversible cessation of neurological function is permanent cessation. So, what's the distinction of changing this terminology from what the law actually says to what the clinical guidelines said? Well, this is saying that we will not attempt to reverse it. And this is different from saying it cannot be reversed, whatever the neurological injury is. The guidelines also said, both in 2019 and in 2023, no, you don't need to get informed consent unless it's required by state law. And then finally, this was the biggest kicker, is the AAN guidelines said that physicians can declare a patient dead by neurological criteria despite the persistence of neuroendocrine functioning. So you can see here, this is in stark contrast to what the law says. So what was the reasoning from AAN? AAN said, well, if the patient is beyond recovery or near death, we should permit an exception. Demise is inevitable, and the patient is close to death, so they're dead. So this is a problem, right? That the clinical standards were trying to essentially rewrite the law. which they don't have the authority to do. The law says that clinicians can create standards, but they can't overwrite the law. So this had generated a significant controversy in trying to figure out, well, what's going on, right? Because it looks like some patients are close to death. They may not be fully dead. For example, if there's biological processes that are still going on in the body, like growth, gestation, wound healing, response to incisions, something is still functioning in the brain to cause these actions in the body. So then the question is, well, perhaps we're just not capturing it. That is, the physician is doing all of these tests correctly, but they're not sufficient to measure all neurological functioning in the brain. So we're testing for partial loss of functioning, but not the whole loss of functioning. So lots of controversies here. So as I mentioned that there's kind of this rift in among clinicians saying, well, we can just kind of minimize what's happening with parts of the brain, the hypothalamus or endocrine functioning, and just call them dead. And clinical guidelines, as I mentioned, can provide a blueprint of how to conduct the exam, but they cannot overwrite the law. And this is significant for physicians that if they're following the AAN clinical guidelines, they are not complying with what the law says. This puts physicians in a very thorny position. So how can we reconcile the conflict? Well, the Uniform Law Commission tried to do this by gathering different input from clinicians and ethicists and legal scholars of, well, should we change what the definition is and sweep in these patients who are almost dead but not quite dead and allow this exception for some residual neurological functioning? And the Uniform Law Commission could not reach a consensus. So, what do we do with this? Well, until states revise their laws, the law still stands that the declaration of death requires that physicians use accepted medical standards, but they need to be assessing whether or not the patient has suffered irreversible cessation of all functions of the entire brain. Now, there has been some clarification of this, that it's a functional, not an anatomical assessment. So it doesn't have to be loss of every neuron, but the functions of the brain. Now, the problem of inadvertent misdiagnosis. So two things and false positives. So false positives, the first bucket would be if physicians are following the clinical guidelines, but the exam is insufficient. That means they're doing everything right, but it's still missing something that's happening in the brain. And that's where we see some of the patients where everything was done correctly, but for some reason, they're still growing, gestating a fetus, their wounds are healing. So that's a problem. The second problem is something that's been less discussed, this a problem of inadvertent misdiagnosis. So physicians who think that they're conducting all of those clinical check boxes correctly, but are skipping or missing significant steps. And by that, I mean not looking for mimicking conditions. So, not ruling out drug intoxication or hypothermia, not performing an apnea test, or perhaps most problematically, I would say I gasped when I saw this, is performing the apnea test. But then, if patients gasp for breath, performing additional tests to confirm death to make sure the patient is dead. But if the patient breathes during the apnea test, the patient's not dead. So you can see these two buckets pose some concerns. So why does it matter of getting this right and fixing these issues? Making sure that we have integrity and honesty when we're dealing with patients. Trust that we are giving a correct misdiagnosis, that there's this bright line, non-maleficence of not harming patients, the moral certainty of making sure patients are dead. If anybody is of my generation and seen the Princess Bride movie, close to dead or near dead is not dead, right? We want to make sure that the patient is dead. And of course, avoiding moral distress. So, what do we do with this? Well, we know that the law still requires potentially informed consent. So, this would be something to check with hospital policy. What are we supposed to do about this? To interact with patient family members who are objecting. And second, that the clinical standards do not have the authority to change the law. So, it still requires irreversible cessation of all functions of the entire brain. And the goal is to uphold all of these ethical principles that I mentioned. Thank you so much.
Thank you, Catherine. We'll open it up for questions, and while we give people a moment or two to stew, I've got a few. You so there are some people that take the position that because that Uniform Law Commission in 2023 was not able to reach a consensus, that it was not necessarily a failure of some sort. It was really a reaffirmation that this is simple, it is clear, it is elegant, it should stay as it is. And it's not the law that needs to change, it's clinicians that need to
Mm.
find a way to really fit into that law better. Is that kind of your position as well? Or would you love to change the Uniform Determination of Death Act if they just said, Catherine, here you go. You get to make whatever you want. What would you put in there?
Yeah, great question. So I think I think it does come down to, and this is based on conversations that I've heard around this, is people have very strongly held entrenched opinions about this. And based on what I've heard from a lot of physicians, and also some law professors, is this idea of just give physicians more authority to kind of change the law and do as the AAN guidelines suggest. And again, I think this is kind of shifting the balance of power. So I think the the way the law is set up now is kind of a good, I don't want to say compromise, but a good goal of making sure that we have clarity and certainty. But I do see quite a bit of frustration or pushback from clinician side. Not all, but some.
Yeah, I get it. The words that stuck out most to me in your paper was that term, the bright legal line. And it's I mean you have both hats. You work in ethics, you work in law. And there's this bright legal line that feels so nice and clean. And then there's the hairy, soupy, messy humanity of what medicine really is, that gray area of ethics. And humanity can't even agree as to what it means to be alive and what is the meaning of all of this. And so they're not going to agree to death as well. And I think there's always going to be that mismatch of some degree, and then just trying to find a way to bring them together the best you can.
Absolutely. And I think it's important when you're talking about the mismatch or not agreeing. I think the important thing here is being clear on terms and being clear on what our position is. So I think where part of the issue comes from is feeling like patients, potentially from the patient angle, or society feeling like they were misled. And so what I've seen again from I would say another side of physicians, exactly like in the comment, is, well, this is a mandate to improve testing, and this is, well, how can we figure out how to do this better, and serve our patients better and give them more certain answers.
Are, so I saw you saw Richard's Richard's comment there. Um, do you have any insider knowledge? Are there any efforts going on to try to research any of this? This feels a little bit outside of your wheelhouse, though.
Yes. So what's interesting about that question is when I was doing, so the research on this was probably a couple of years ago, and there might be updates since, but the studies that I was showing on like the inadvertent misdiagnosis, that's old stuff. You probably saw the years were a few years ago. So I don't know if there's anything new that's actually been published on this or anything new that's in the works. But there should be, just not me doing it. Leave that to the experts.
And then one last question is why is there this push to get rid of the gray area? That was one of your terms. It feels like we would love it to just be clear they're either alive or they're dead, rather than embracing that this is so gray and challenging and having, I assume it has to do with a lot of things, but maybe it's time, maybe it's organ transplant. But to sit down and tell a family this is a really devastating injury. They are almost dead, but there still is X, Y, and Z. Maybe it's to try to erase some of that. Is it time? Is it? But it just feels like there's this push to to get rid of the gray area, to use your own words.
Yeah, I think that's a great point that I think it is probably both the legal issue of we want, what was the time of death? I do think there is a significant overlap with organ donation, and I don't know how many on the call saw the kind of the controversy over determination of death and how that's overlapped with organ donation and patients who kind of this, I would say, sensationalized, probably much bigger, made into a much bigger issue than it is, but patients who were alive when their organs were retrieved, the HHS report. So we want to be sure for a lot of context, but especially in that context. Do I have time to answer the chat questions?
Oh, please do. We'll give you all the time you'd like.
Okay, public opinion changed on the topic over the years. So I think there has been more of a recognition of some of those outlier cases um, where in some instances families were objecting to the brain death diagnosis, excuse me. And then we started to see, well, wait a minute, the patient isn't deteriorating, right? Their body isn't deteriorating. What's happening? So I think that's part of what changed public opinion. Those very rare cases, like the Jahi McMath case, the Marlise Munoz case, cases like that where we saw something still going on. What's happening here? And I think that's part of what's changed public opinion. Other countries that have a more cohesive evaluation process. What I don't know much about this, but what I do know about other countries is some do not require all cessation of all neurological functioning. So some go by a higher brain functioning standard, which again is slightly different. So that's a much larger question of is one better or another? But that's as much as I know about that.
Lovely. All right. I think we answered all the questions. Catherine, thank you so much. It's a pleasure as always to have you with us.
Yes, thank you so much. Have a great day.
All right. Bye, everybody.